Regius Professor of Medicine at Oxford University, Sir John Bell. Thank you so much for joining us this morning.
Yeah, nice to be with you.
You spent a career learning about disease and immunology. There's not much about variants you don't know about. The two variants we're dealing with at the moment, the UK one, the Kent one, and the South African one, which one worries you more, can I ask?
Yeah, the South African by some margin. They both have multiple different mutations in them, so they're not a single mutation, they're multiple different mutations. And the mutations associated with the South African form are really pretty substantial changes in the structure of the protein. So the protein has got a domain which binds to the human cells. It's called the receptor binding domain, and it's where the virus attaches itself. And so if you get an immune response that protects you, one of the ways it protects you is it gets in the way of that binding event. So you rely on antibodies to bind to that domain to stop the virus from binding onto your cells. That's basically the whole basis for vaccines. There are a number of monoclonal antibodies that work that way. And that's why if you get an infection, you make antibodies to that domain that prevent you getting reinfected. So if you mess around with that, you're in trouble. And the first variant, the so-called Kent variant, has a number of mutations that are not in the receptor binding domain. And the one mutation which is really dominant in the receptor binding domain is only on one bit of that domain. So the best way to imagine it is two shoulders and a neck. There are two shoulders and a neck to the receptor binding domain. The 501 tyrosine mutation is on one shoulder. Can kind of live with that because there's lots of other places you can mess around with the receptor binding domain if you make antibodies to it. The South African strain, again, multiple mutations, but it's got 501Y, and it's also got a mutation at 484, which is on the other shoulder, which is a very big mutation. It's a lysine change for glutamic acid, so it changes the electrochemical basis for that interaction. And yeah, there isn't going to be any antibodies that stick to that. So I would worry a lot about the South African strain.
So the Kent strain, although it's more virulent, it's no more dangerous if you catch it. The South African strain is more dangerous if you catch it. It's harder to fight off.
No, there's no data. It's more infectious for sure. Although the South Africans are clearly struggling with it. They can't give us any real numbers at the moment, but I think it's increase the infectiousness, probably by increasing its ability to bind to the human cells, to the receptor on the human cells. That's probably how that's happening.
And will we have much chance in keeping it out of the UK? Is it controllable?
No, I think it's here actually. So the answer is no. And
how much
the real question is, do the vaccines that allow you to make antibodies to a wide range of sites on the spike protein, are those sufficient to neutralize the virus, or are in the presence of the mutations, will they be disabled, as it were?
That was my very next question. How will the vaccine tackle either variant? Do we know? Have enough information yet?
It's a crucial question, and we're the team. The team here in Oxford are looking at that right now to see whether, because obviously we now have the new variant strain and we've got all the antibodies produced by the vaccine in 20,000 people. So we can take those antibodies and see whether they neutralize the virus. And that's the work that's going on at the moment. And I can't give you an insight. Now, if you want my gut feeling, is that I think the vaccine will be still effective against the Kent strain. And I don't know about the South African strain. I think there's a big question mark about that.
So the two current vaccines we have at the moment, Pfizer and AstraZeneca, may not be able to protect us against the South African strain, which you think is already here.
Yeah, I think there's evidence that it's onshore. I think there are sequences around for it. I think it's at very low levels, but it's very difficult in the modern world. That was, I think, the reason that transport links were severed with South Africa, was there was an anxiety that with transport links in place, you were inevitably going to get it. So the real question is, are the vaccines going to be adequate? And remember, the vaccines have got we got a bit of headroom with the vaccines because they work, I think, much better than any of us thought they were going to work, and they essentially completely prevent severe disease. So, we do have some room to maneuver. They worked 20% less well because of a mutation, we'd still have good vaccines, in my view. I think it's unlikely that these mutations will turn off the effect of vaccines entirely. I think you'll still have a residual effect. So I think it's a real question about whether we can play that out and make it work. If we can't, it's perfectly possible to make new vaccines. So, and that will not take a year. That will take enough time to get a signal as to what immune responses you make to a new vaccine, and probably a bit of safety data, although I don't think you'll need much safety data, because the only thing that's changed would be those few residues in the spike protein. So it might take a month or 6 weeks to get a new vaccine. So everybody should stay calm. It's going to be fine. But it's, we're now in a game of cat and mouse, because these are not the only two variants we're going to see. We're going to see lots of variants.
Yes. So we may well need a new vaccine for the South African strain, if I can sum you up. But though we may have to wait a little bit longer for that one, don't panic quite yet.
Yeah, I don't think there's any need to panic at all. Now that we know we can make vaccines to this pathogen rather well, I think we're in pretty good shape, actually. So, so I think but I think the real issue will be to keep our eyes open for new vaccines, because as you get for new viruses, because as you start to immunize the population, you're creating a selective pressure on the virus that will make it more likely to evolve to different structures that evade the immune response generated by the vaccine. So there will be a real need to keep monitoring the sequences of the virus to see whether it changes over time. I think what's quite interesting is that the UK's done okay on a few things. I mean, we've obviously done okay making a vaccine. We've done okay getting mass testing off the ground, probably better than anybody else. And we've also done very well on monitoring the genome sequence of the virus. And that's been going on for months without much interesting popping up. And then suddenly, within a very short time frame, we're starting to see activity. In the US, they've done very little sequencing. Here's the heartlands of biomedical science in America. The problem is, in a private healthcare system, your swab goes off to a private lab to be diagnosed, and nobody keeps the culture, and nobody sequences the culture. So, it just shows why it's helpful to have a single unified public health system in the UK.
Let's talk a bit about the AstraZeneca Oxford vaccine. Now, you played quite an important part in that, did you not? It was your phone call to the CEO of AstraZeneca, Pascal Soriot, that began the whole partnership, was it not?
Well, look, I don't want to, all the real heavy lifting scientifically has been done by the team at the Jenner and the Oxford Vaccine Unit. So, and I would single out Sarah Gilbert, who led the original work, and Andy Pollard's been doing all the lifting on the clinical trial. So my role compared to those two is tiny. So I just want to be really crystal clear about that. They've done all the heavy lifting. There has been some stuff around the edges, though, that has been quite important. So it became very clear to me in February, as they were running full tilt into a clinical trial to develop a vaccine for the world, that the university was not at all equipped to do half the things you would need to do to make that work. And so I took on the responsibility of helping to find a partner to make that work. And we ended up, after a relatively short time frame, we ended up with AstraZeneca. We're delighted with them as a partner. They've done a great job, and that's worked out pretty well. And I've of course stayed involved in the program, helping to manage some of the the political issues around the side, both with government and with AstraZeneca. So my role has not been a hands dirty role, but it's been a kind of oversight role, which I think has helped.
Sure. Let's talk about production. That is what everyone wants to know about desperately at the moment. Oxford and AstraZeneca have taken on orders for this vaccine around the world, haven't they? There is huge demand now. How confident are you that the company can produce the 2 million a week doses, which scientists here say is what is needed to get on top of this new variant?
Yeah, so I'm confident they can get there, and I'm pretty confident that they can get there in a relatively short time frame.
What does that mean?
My understanding is that there's 530,000 doses sitting on the shelf as of yesterday. And there's another 450,000 arriving on Monday. So there's 1 million doses ready to go. They are then scaling up as we speak manufacturing capacity so that by the following week, you'll have a flow of vaccines growing to 2 million by the middle of the month, 2 million a week by the middle of the month.
Just for the UK?
Just for the UK, yeah. Now, there are other suppliers around the world who are also making this, mostly for their home domain. So perhaps the best example is the Serum Institute in India, which is one of the world's biggest vaccine manufacturers. I'm told that they have close to 100 million doses made, but that's to supply India and the big Gavi countries in Africa. So, you can scale this if you really get going. So I'm optimistic that we'll get in a place that we can really provide the supply that we need. But you're absolutely right to focus on it, because actually now that we've got a vaccine that's deliverable really easily, and you can line people up, you can give thousands of these a day from a single site. You've got to make sure the supply services that demand, because there will be a massive demand, I'm sure.
Well, the Chief Medical Officer, Chris Whitty, has said very recently that vaccine shortage is a reality that cannot be wished away. He seems a lot more concerned than you are about delivery.
Yeah, well, so let me put it this way. I'm not sure 2 million a week is the right number. I think we could do many more than 2 million a week. The real question
you could produce more.
Well, I think we could. I think you could distribute more. You can't distribute more than 2 million a week of the Pfizer vaccine. I mean, we've only managed to get 1 million out the door in a month. So, there's certain practical constraints with doing the Pfizer vaccine. But just to put it in perspective, the NHS delivers 20 to 30 million doses of flu vaccine in October and November every year. That's more than 2 million a week.
So you're saying AstraZeneca can supply millions of doses a week. It's up to the NHS and the government to then deliver them, and that is something they're very capable of doing.
Yeah. So if you put those, if you get AstraZeneca to really gear up production and find mechanisms to produce more than 2 million a week, there's no problem, in my view, administering more than 2 million a week. I suspect you could administer 5 million a week if you wanted to. If you really wanted to, you could do as many as you want. It's easy. You don't have to be a doctor. You could administrate the bloody thing. It's not complicated. Just stick a needle in somebody's arm. So you just need a doctor there to sign the prescription. So, this is entirely a sort of logistic issue rather than anything else.
So why the caution in government? What is the biggest problem here? Is it supply, or is it of your vaccine, or is it delivery of it by the government?
No, I think at the moment, in fairness to the government, it's supply, because AstraZeneca really does need to step up and produce large amounts of the vaccine. So I think that, in fairness, is the issue. I think if we could produce, and if we do produce 2 million a week by the middle of January, then I'm sure the NHS can deploy that without any difficulty at all. If we produce 5 million a week, I suspect the NHS can deploy that as well. So
you think AstraZeneca can produce 5 million vaccines a week?
Well, the Serum Institute of India has produced 100 million doses. So, work that out. They started in September. So, I just, now, I don't want to understate the complexity of making a biological vaccine like this. It's complicated. And sometimes you put it in big vats, you scale it up, and then you get into the process and the thing doesn't work for a whole variety of reasons. There's still lots of variables. So sometimes you get a batch which you think is going to be fine and it doesn't work out. So batch failure is a significant problem. And of course, if you get a batch failure, you might lose as many as 1 million doses of vaccine from a single batch failure. So I don't want to trivialize it, because those, AstraZeneca have done a terrific job getting to where they've gotten to. And it's really up to them to really see what they can do in terms of scaling it.
Well, look, this is a $69 million question. You may not have the answer, but what is your gut instinct on, realistically, how many people the government would need to vaccinate, and by when, to allow it to start reducing social distancing restrictions?
So I think first of all, just to say this is a policy question. I don't do policy, somebody else does policy, but you're just now asking me as an observer what I think the right answer is. And I think if you get through all those high risk groups that are on the priority list, that's whatever it is, 8 groups of people, there's about 26 million people. And if you're trying to get this vaccine to stop people from getting seriously ill, which it does with 100% efficacy so far. And the Pfizer vaccine, the same, 100% efficacy, which means no serious disease, no people in ITU, no people dying. Then 26 million should be enough to get us back to where we need to be, because you've basically taken all the people who were going to end up in hospital and you said, well, you're not going to end up in hospital now. And then, you know, will there be people who get a sore throat and a cough? Yes, there will. Will there be people with virus up their nose? Yes, there will. Does it matter? Well, it matters a bit, but it doesn't matter so much that we have to be locked down.
So that 26 million, potentially, we just discussed the rates of delivery and production. If you're at 5 million a week, say even 2 million a week, that's what, between 5 and 10 weeks.
Well, I said Easter, didn't I? I'm sorry, I've been hung out to dry on my comment about Easter, which I got caught with at an interview. But I turned out it was not a bad guess. I think Easter probably is a reasonable time to start thinking about at least moderate returns to normality, people being able to travel and use public transport and go to work and meet others in the pub and all that stuff. Now that, look, there's lots of ifs on the way. You know, could you get a variant that messes all that up? Yes, you could. You know, could the disease get completely out of control? Yes, it could. Could the health service fall over? Yes, it could. And there's all kinds of stuff in the way. But the reason I'm anxious to push vaccines really hard is the best way to avoid those kind of troubles is to get as many people vaccinated as we can in the shortest possible period. That puts an enormous pressure on AstraZeneca, but in fairness to them, they've done a terrific job up to now. So I've got great confidence that they can do a lot.
Sure. And until we get to that stage, because the Kent variant, the South African variant now is so transmissible, so virulent, you would not be able to really foresee any ability by the government to reduce the current stringent tiering. In other words, most of the country should really expect to be in at least tier 3, if not tier 4, until that magic moment, be it Easter or before. Yeah, no,
it might get better on the journey. So as you immunize more people, there's less people out there to spread the disease. So the R will naturally fall as you get a growing population of people who are both convalescing because they've had the disease. And if you look at the numbers out there now, you're going to get quite a large number of people who've actually been exposed to this disease, and then the vaccinated population. And if you add all that up, that will definitely reduce the R significantly. So you know, it won't be a cliff edge. It'll be gradually getting better over time. And then there will have to be a policy decision about what is the extent of risk and at what moment can we open society up again, or it's likely to happen in stages. So, you know, to get some things to open and then others. But I think that would be my view.
Sure. And final question for you, Sir John, you've been very generous with your time. You would, I'm sure, agree with the government's decision to move priority vaccinations to as many people getting the first dose only. But to those who only have one dose, the old, those more at risk, should they feel safe enough with just one dose inside them without getting the second dose to go back onto the streets, start meeting their family when the government says they can?
Yeah, so I want to be very reassuring about this. So the Pfizer data is very compelling, and that is that a single dose appears to protect people up to the level of about 90%. Now, the advertised number is 56%, but that's because they included people in the first week who'd only just had the vaccine. If you wait till people have got an immune response from the first dose, they are essentially protected from the disease. So people don't need to worry. Similarly with the AstraZeneca vaccine, the first dose of efficacy is 73%. It's pretty good. And that will protect everybody from severe disease, hospitalizations, ITU, all the rest of it. Everybody gets it, so it's fine. So the real question, which you're now going to ask me, is, well, why do the second dose? Well, the answer is that the immune response, to have prolonged, durable, effective immune response, you really do need a boost. And most of the vaccines we give for most diseases, we have 2 doses. And the reason is the first dose gets your lymphocytes fired up, making some antibody, makes a particular type of antibody called IgM. That decays over about 30 days. And then you give a boost later to turn the memory cells into the cells that produce lots of antibodies, but antibodies that have changed so that they're much higher affinity for the virus. And it may well be that a longer period before you give that second dose will produce better antibodies that actually fight the virus better over a long period of time. So there's some very good scientific reasons. We don't have a lot of data. So, you'll say, well, what's the data? Well, the answer is we don't have any data, really. We've only had one trial and been watching stuff over the past few months. So, and the numbers are quite small. But we will get better data over time. And I think that's a really important issue. But I don't think people need to worry about having a single dose of the vaccines. The vaccines work really well after a single dose.
So John Bell, thank you so much for joining us this morning. Really appreciate your time.
Great. Thanks so much, Tom.